Brian Shuch. I'm the director of the UCLA Kidney Cancer Program, a urologist, very involved in clinical trials and translational research. So today, it's become an epidemic of small renal masses. Due to the aging population of the US, due to the obesity epidemic, and due to the availability of CT and MRI scans with thinner and thinner cuts, we're finding more kidney tumors than ever before. We have 4 times more kidney tumors today than in the 1970s. But the same number of patients are dying each year. But we're treating 4 times more patients surgically. So what does that mean? There's a disconnect. And clearly there's a lot more patients who are getting treated that were never destined to die of the disease than those who actually really must have treatment to help save their lives. So we do know that there's over-treatment. We also know that some patients have benign tumors. We know that they may be unnecessarily treated. So it's really paramount for us to understand if we see a tumor, we don't necessarily need to always go in and treat it with an aggressive approach. So better understanding what's in a patient's body, better understanding really what their treatment goals would be, what their life expectancy is very important to try to basically allow us to treat the tumor's biology with the appropriate treatment, whether it's observation or whether it's removing it. So, we should try to match the tumor biology to the treatment intensity. So small renal mass is technically defined as a tumor less than 4 centimeters. We call that usually a clinical stage T1A. That is now accounting for about 50% of the kidney tumors that we see. And the number of new cases each year has gone up dramatically, and most of those new diagnoses that have changed over the past 30 years have been small renal masses incidentally diagnosed. In the 1970s, it was very different, where most patients would come in with flank pain and abdominal mass or blood in the urine. But now we have really this epidemic of these incidental asymptomatic lesions, and a lot of those could be benign, or a lot of those could be something that's more indolent or slower growing, less aggressive. And occasionally we see aggressive tumors that are destined to hurt someone had they not been found early. So the ZIRCON trial was a pivotal, large, international phase 3 trial looking at a novel PET tracer called girentuximab, labeled with zirconium, a radionuclide, which can identify clear cell kidney cancer, which has on its surface a marker called CA9. So PET scan has long been used across many different fields. The problem with clear cell kidney cancer is that FDG, which is radioactive glucose, does not usually take up the tracer, and the sensitivity is quite poor. So the other issue, when we give a tracer, if it gets taken up by the whole kidney, a tumor in the kidney can hide. And so you need to have a tracer which would not be taken up by the kidney and also have very high specificity for that target cell. So we do know that CA9 has been expressed on the surface of 95% of clear cell kidney cancers, and we have this antibody which can be given and allow for imaging. So this trial was a image and then resect trial, where there were over 300 patients that had the injection of the agent, and then 5 days later they had the PET CT, and then everyone went for surgery. What we learned is that the positive predictive value for tumors that were positive on the PET scan, 94% of them were actually clear cell kidney cancer. So that is something that will likely be very instrumental in our management of a renal mass, when we know that 30% of patients who go for surgery unfortunately have benign lesions only found after the fact. So by having an agent which can reliably detect the most common form of kidney cancer is going to be very, very helpful to help us start avoiding over-treatment. So if we take patients and we image them, we're going to know and confirm that they actually have disease which needs to be managed. And I think it's obviously not yet FDA approved yet, but there's a biological license application submitted this past year. And we do hope that it is something that becomes available to our patient community in the near future. This is step 1. Step 2 will be trying to use the same PET scan agent to diagnose patients with disease outside the kidney. And we do have a trial ongoing to help patients after surgery with a clear cell kidney cancer get imaged. It's called K9, and we'll be presenting this at the Kidney Cancer Association meeting as a trial in progress. But there are ongoing efforts to image larger tumors. There are also ongoing efforts to image patients with suspected metastatic disease prior to a biopsy or surgery. So it's just the beginning of a totally transformative effort to help us use nuclear medicine to aid our diagnostic algorithms. So, as a urologist, and we take out, large tumors and we try to hopefully cure patients, it's always disconcerting when you do a major operation and then 6 months later, a year later, there's disease that recurs. So the Keynote 564 trial was really a landmark trial to show that immunotherapy has a role in reducing risk of recurrence. It does appear that some patients are potentially living longer with a small 5% or 6% overall survival advantage at 48 months. But there are ongoing trials which we're very excited about, one being the LIGHTSPARK 002 trial, where they're adding in belzutifan, which is a very well-tolerated oral agent approved for metastatic kidney cancer and for hereditary kidney cancer, VHL disease. And we're hoping that will improve our efforts to prevent recurrence. There are other trials that are also moving forward, and the Cooperative Group Alliance has a STRIKE trial where they're trying to intensify the treatment with a TKI on top of pembrolizumab. So it's a really exciting time for patients who we know we're going to put through a major operation, that we do think that they have higher risk of recurrence. We have tools which will be able to hopefully ensure that they really are cured of their disease. So knowledge is power, and I think getting patients more information can help them better understanding of what's in their body. Everyone hears the word cancer, and they obviously want to think about, oh, I need to run to surgery. We have an ability to try to tell them that they can take a deep breath, they can step back. We have the ability to get them more information. And that information is readily available, whether it's more imaging, whether it's a nuclear medicine test, whether it's a biopsy. We have a lot of tools to help better risk stratify patients so we can give patients the appropriate treatment. Unfortunately, most of the patients who we diagnose with the renal mass are going to be older. The median age is 64, and a lot of them have some risk factors, whether it's obesity, chronic kidney disease, diabetes. So not every patient would benefit from upfront surgery. Some of them would be better served with getting more information and guiding them appropriately, whether it's surveillance, whether it's an ablation, whether it's radiation, whether it's surgery. We need to help patients better understand what's the best choice for them.